everyone, my name is Kelsey. I'm one of the emergency medicine residents at Temple, and this is my presentation, ICU Upgrades, Misdiagnosis versus Mistriage. I have no disclosures. So, for the attendings in the room, it's time to go back to residency for the next 45 seconds. So, it is February of your intern year. You are on your ICU rotation. It's 3 o'clock in the morning. You just absolutely nailed a central line. You're working on a coffee and you're holding the rapid response pager when all of a sudden that pager starts alarming. It's the 4th floor. They have a 72-year-old woman who is hypotensive, tachycardic, and just wasn't acting right when the nurse went in to check on her. You know exactly what to do. As soon as you hit the floor, you know which room it is because there are about 100 people standing outside. As you fight your way to the front of the room, the scene begins to unfold in front of you. The code cart on your right-hand side is upside down. Directly in front of you, the patient's 27-gauge hand IV that fluid is being pressure bag fluid just blew. To your left, 2 nurses are in a physical altercation over whether the patient has a pulse, and on the floor next to you, a trash can is on fire. As the savvy and know-it resident that you are, you fight your way to the front of the bed, take control of the room, command the resuscitation, begin transport up to the ICU where the patient is intubated, started on their 3rd pressor, and guess what? You get your 2nd flawless central line of the night, and you think to yourself, we the best, right? But as the introspective and thoughtful resident that you are, you think, maybe that patient should have been directly admitted to the ICU instead of going to the floor at all. Which brings us to the topic of this presentation, ICU upgrades. So it comes of no surprise to anyone that patients occasionally will decompensate while on the floor or a non-critical care setting requiring an upgraded level of care. In the largest cohort study of its kind, looking at about 317,000 patients, they found roughly a 5% incidence of ICU upgrades. We know that these upgrades typically occur within the first 72 hours after admission, often peaking at that 24-hour mark, and that these upgrades are associated with high mortality rates, significantly higher than that of those patients who are upgraded, who are admitted directly from the ED to the ICU. Temple is a large tertiary care facility. We take care of a lot of very sick patients, so we wanted to ask ourselves a question. Why were patients being upgraded from the floor to the ICU, and what was the ED's role in it? To answer these questions, we conducted a retrospective chart review over a 4.5-year period. We accounted for all ICU upgrades within 48 hours of admission. We subsequently stratified these upgrades into progression of illness. Did grandma's pneumonia just get worse? And then we looked at some ED-specific criteria, things that we could potentially do better, mistriage and misdiagnosis. We then assessed mortality rates and we identified the most common causes of diagnoses. So, to identify patients that were mistriaged, we wanted to use objective criteria, or as objective criteria as possible. We used early warning score and the QSOFA criteria. So if at any point a patient had an early warning score of 5 or more, they were considered mistriage. Similarly, for QSOFA, if at any point during their ER stay they had a score of 2 or 3, they were considered mistriaged. Misdiagnosis was a little bit more straightforward. We simply compared admission to discharge diagnoses, and if they were non-concordant, they were included in that cohort. So what did we find? 311 patients over the 4.5-year period were upgraded to the ICU. 43 patients expired, accounting for a total mortality rate of 13.8%. The vast majority, 72%, 224 patients that were upgraded as a result of progression of illness, with a mortality rate of 8.9%. And if we look at our 2 categories of interest, mistriage and misdiagnosis, we find that they comprise the vast minority of upgrades. However, their mortality rates were nearly 3 times that of the progression of illness group, 28.5% and 28.3% respectively. If we break misdiagnosis into diagnostic categories, we see that sepsis accounted for more than half of the diagnoses. And if we look at the patients that died with a misdiagnosis, sepsis accounted for more than 3/4. So what can we take away from this data? First is that most upgrades are related to progression of illness. We see that sepsis is the most common misdiagnosis, accounting for 78% of the misdiagnosis deaths. Interestingly, mistriage is an uncommon reason for ICU upgrade, accounting for roughly 4 cases per year. And importantly, we've seen a trend at Temple towards declining sepsis upgrades. In 2018, we only had 3 cases with no deaths. So, as the introspective, thoughtful, and hungry resident that you are, you can focus your attention to more important tasks, such as when does the hospital cafeteria open. With that, I want to thank you, and I'll do my best to address any questions you might have.